Hello, everybody. Good morning. It's a delight to be here and a delight to get a chance to talk with you. Thank you for coming. Um, what we're going to talk about is a few aspects that are of interest to me in regard to facilitating trauma recovery. And we're going to cover a few things. First of all, we're going to cover some basic definitions. And then we're going to cover aspects of what was called the Adverse Childhood Experiences Study, which taught us a lot about trauma. Then we'll go into some historical information. And then lastly, we'll cover some approaches that I think help better facilitate trauma recovery. So that's what we're going to cover today. Again, welcome. Well, the first thing in terms of the definition is what is psychological trauma? How do we define it? People have a lot of different ways that they go ahead and define that, but I have two that I use. And the first one is that anything that overwhelms our capacity to cope effectively with what we're going through in life, I see as psychological trauma. The other thing is that trauma comes from the ancient Greek word trauma, which means wound. And the ancient Greeks were talking about physical wounds only, but it's a good way to look at psychological wounds. So I see that anything that causes wounding to our hearts, our souls, or our spirits is psychological trauma. So, with those definitions, all of us experience some degree of psychological trauma in our lives, some just much more than others. So, that's how I see psychological trauma and how we define it. The second thing is I want to talk about there's two major kinds of trauma. The first one is what we call event trauma, and that is something that happens to us in our lives. And it could be something like a medical complication, a fall or an accident, being involved in a car accident, experiencing a physical or sexual assault, going through a natural disaster, being in a situation where you're a first responder and come against really difficult situations that affect the individual. So all of those are event traumas. And event traumas not always, but sometimes can lead to what we refer to as post-traumatic stress disorder. The other kind of trauma that I think is what we call complex developmental trauma. And you'll hear people use different words. They'll use complex trauma, developmental trauma, betrayal trauma. What we're talking about is it's not a single event that creates the trauma, but it's that I grew up in a traumatic environment. So it's not just one event, but throughout my childhood, there has been traumatic events. So what I look at is that how do we know if we have complex developmental trauma? If we lived and grew up in a house where we have a scary caregiver, someone that we're frightened of, that we have to walk on eggshells around, or we live in a scary, frightening environment, then that would lead to what we call developmental trauma. Now, the interesting thing is that the DSM-5, our diagnostic book, has no category for complex developmental trauma. They focus on event trauma, things that happen, but they don't focus on complex developmental trauma, and they don't even have a category for it. So we actually have to refer to it as other related and trauma stress disorder problems. So there's no category for that. And the ICD-11, there is a category for complex developmental trauma, but the DSM has not caught up with that yet. Okay, so what happens in complex trauma is there are multiple areas that are affected. We are affected in terms of our basic trust, our basic ability to attach with others, our basic ability to regulate our emotions, our tendency towards poor awareness, and a tendency for dissociation, physical problems, and some degree of somatization. Those kind of things are all affected. So developmental trauma affects the whole person and not just one or two things or aspects. So it's not just symptoms, but it's a variety of aspects about our lives. Okay. Now, interestingly enough, most complex developmental trauma does not result in post-traumatic stress disorder, but what it results in is other psychological problems, which include mood disorders, anxiety disorders, substance abuse disorders, eating disorders, impulse control disorders, personality disorders. all the gamut of psychological problems basically can be attributed in many cases to complex developmental trauma. Now, the other thing is those of us that do have complex developmental trauma are much more likely to develop post-traumatic stress disorder when later we have events that could be traumatic events. Okay, so those are what I think of as the two kind of problems, and those are basic definitions. Now, where do we get this information? And that is mostly from what's called the ACE study, or the Adverse Childhood Experiences Study. This was a study that was done as a joint venture between Kaiser Permanente Insurance Company and the Center for Disease Control. So it was a public-private venture out of Georgia, Atlanta, where the CDC is located. Now, it's not a small study. It's very large. They enrolled 17,000 people. That's a huge study. The demographics were that it was about half men and about half women. About 70% were white, and about 30% were people of color. The age range from 18 above to mostly 65, and some older, but the average age was people in their 50s. And then they were all in a middle-class socioeconomic group because they had Kaiser Permanente insurance, or their family members did. So this is what I call a slice of mid-America. It's not a high socioeconomic group nor a lower socioeconomic group. It's basically what we think of as middle America, or middle-class America. Now, what they were looking at 10 things that could happen to children, and they looked at 3 types of abuse: physical abuse, sexual abuse, and emotional abuse. They looked at patterns of neglect, which included physical neglect and emotional neglect. And then they looked at 5 types of adverse experiences that children could experience, such as being at a home where one spouse is violent to the other, living in a home where a parent is mentally ill, coming from a home where there's early divorce, living in a home where one member is incarcerated, those types of things. And they were strictly defined. And what they were looking at medical problems. They were not looking for psychiatric difficulties, but they were looking for how adverse childhood experiences affect physical problems. Now, the interesting thing is they come up with a very surprising finding that nobody expected to find, and it's very striking, and that is 25% of the women in that study reported at least one episode of sexual abuse before the age of 18. About 25% had one event of physical abuse. Men were about 14% reported at least one episode of sexual abuse before age 18, again with the same number, about 25%, having at least one episode of physical abuse. Now, this was a striking finding, and not anybody expected that, because this does not include all those men and women who are physically or sexually assaulted when they're over 18 and as adults. This is just under 18. That's a huge number, and it was very striking. And it was that information that first got us looking at how many other psychological problems are a result of these types of traumatic events. Now, I want to talk a little bit about the historical information, and that is, when did we first start thinking about trauma as being related to abuse in the home? When do you first start thinking about more complex developmental trauma? And it actually starts with one of the first psychiatrists that most people are familiar with, Sigmund Freud, who practiced in Vienna in the 1890s and early 1900s. Now, his first paper that he presented to the Viennese Psychiatric Society was called The Etiology of Hysteria. Now, etiology meaning the cause of, and hysteria was the word that they used for any women's psychological problems at that time. They referred to as hysteria. In his paper, he presented information from 18 cases that he had, and he said of all 18 cases that he was presenting, childhood sexual abuse was the cause of hysteria. This did not go over very well at all. He was ostracized from the medical and psychiatric community for saying such a thing, and for 4 years he had no colleagues that would speak to him at all. He did have one, a Dr. William Fleiss, that he was able to communicate with letters by, and you can still look at those letters. But you can see the work, The Etiology of Hysteria, on the web. You can just Google it and you can read it for yourself. Now, after a while, though, being isolated, he began to change his mind and go along with the more thoughts of the day, which were the reports of childhood sexual abuse were childhood fantasies, and then developed the sort the issue of the psychosexual development fantasies of children, including the Oedipus complex and the electric complex, and those sorts of things. So that set back trauma therapy and trauma issues related to abuse for quite some time. Now, interestingly enough, simultaneously, there was a French psychiatrist, Pierre Genet, and Genet practiced out of France, and he ran a hospital. And he worked with women with hysteria, and they would come in for a significant period of time. He developed a three-phase way of treatment. And the first one, his phase one of treatment, was bringing people in and helping them get their nervous systems back in regulation. He did this by making sure they had plenty of good food, that they had medications for sleep and anxiety, that they had community activities and things they did together, regular exercise, those types of things. His stage two was the processing or reprocessing trauma memories. And the third stage was looking at reintegrating a sense of self and reintegrating the self into the community. Now, about 10 to 15 years ago, I'm not sure exactly when, the International Society for Trauma Stress Studies, which is one of the main trauma organizations in the world, came up with expert consensus guidelines for treatment of complex developmental trauma. And interestingly enough, they came up with a three-phase treatment. The first, regulation of the nervous system. The second phase is processing trauma memories. And the third phase being reintegration to a sense of self, better sense of self, and reintegration into the community. So Genet was doing this 100 years before we were doing this. So in a sense, there's nothing new under the sun. Now, his ideas did not get propagated like Freud's did, however, because Freud was an excellent writer, and you can read any of Freud's work, and they're easily accessible, whether or not you have any background in science or anything. They're really accessible and well written. Genet was a poor writer, and in fact, when you look at English translations of his writings in French, they're very difficult to understand. And even though I know what he's talking about by experience, a lot of times when I'm reading things that he wrote, I can't really quite get what he's trying to say. So those ideas were not propagated. The other thing is that he did not have a series of disciples and a group of disciples, and Freud did. So Freud's ideas more or less took over for a long time. So that's just an interesting, I think, historical sidelight there. And it's just an interesting to read about the history of psychiatry, and particularly in terms of trauma and trauma recovery. There's a lot of information, too, about trauma recovery and trauma treatments during the World War I, World War II, and the Vietnam War as well, and they're very interesting to look at. Now, I want to talk about a little bit of perspective about how we approach recovery from trauma. And the first thing is I tell my patients or clients that trauma is not a disease or a disorder. Post-traumatic stress disorder is a poor name for what is actually occurring. I prefer to use the term post-traumatic stress response or post-traumatic stress injury, because post-traumatic stress disorder implies that you have an illness, that you have a disease, that you have a disorder, that you have something you need to be fixed, that sort of thing. Something is essentially wrong with you. And what I explain to patients is that they may have psychological symptoms, they may have a lot of symptoms, and they may have a great deal of difficulty in interpersonal relationships. But at the core, there's nothing essentially wrong with them. They are having normal nervous system adaptations to traumatic circumstances. And this goes a long way in terms of reducing shame, because people who have complex developmental trauma often think they are bad, unworthy, something's essentially wrong with them. And by starting with this point that there's nothing essentially wrong with them, you really can go a long way in reducing shame. The other thing that I talk about is that when we start to work with the trauma and trauma recovery, we don't refer to it as treatment. I don't refer to it as treatment because treatment implies that you have a disease or a disorder, but I refer to it as trauma recovery. And I refer to us therapists as simply facilitators of trauma recovery, not treatment providers. Now, the other thing is that we always want to start with what I call the positive. We don't want to look at the psychopathology so much as the strength and resources of the patient or the client. For many, many years, we had an approach to psychiatric or psychological difficulties, which was a psychopathology approach, which was to learn, okay, what are the nature of the problems that people have? What are the types of problems that people have? How can we lump them together and group them together? How can we study these problems? How can we come up with proper treatments, etc.? But I think that has served its time now, and it's better to look at a regulation model rather than a diagnostic model or psychopathology model. And a regulation model is more consistent with what we know about neurobiology, attachment, brain development, and that sort of thing. So we're looking at how the nervous system is regulated and how it becomes dysregulated from traumatic experiences. So we focus on strength and resources, and we always start with the positive. Now, I have a sheet that I give people. It's a questionnaire called my resource sheet, and I adapted this from David Kerr, who used to work at Sierra Tucson and was a somatic experiencing therapist, and I borrowed some of his ideas here. And basically, it's a series of questions that are designed to look at what's right with the patient, not what's wrong with them. And this helps where we start off. We also find out the things in their lives that are very useful to them in terms of bringing back good memories or a sense of joy or a sense of well-being. And these are what I call then our anchors, so that when we go into processing trauma memories which are negative, we can help regulate the system as we go through those memories by always coming back to our anchors, the things that brought us a sense of goodness, a sense of well-being, or a sense of joy. Now, I also talk with people that calmness is great, but calmness is not the opposite of trauma, that joy is the opposite of trauma, and that when we work with trauma, there's both negative aspects we have to deal with, but we have to deal with anything that can link or connect or help somebody come in contact with a sense of joy again. And that is what really heals a trauma. So some of the questions that I would ask is, what kind of things, what kind of accomplishments have you had in your life, or what kind of achievements that you've had that you're proud of? I also ask them how animals have been useful to them or helpful to them in their lives. I ask them about places that they've been, which are places that they have good memories of and good thoughts of. I ask them about activities they particularly like and they enjoy when they're feeling well. I ask them questions about who really has understood them in their life, or who's really what I call got them, really understood them at core. And then we also have questions about where they would, what they would say to people who have similar problems and where they'd like to be several years from now. And that's the first assignment that we start with everybody. Now, the other thing is we do have to talk about the negative things, but as we do so, we want to process trauma in what is called dual processing, and that is we want to be aware of what's occurring with us now, here and now in the room, as well as the past, so that you were constantly moving back and forth between the narrative story and what I'm experiencing in the here and now, and this helps us stay regulated. I think regulation phase one treatment is important for everybody. Not everybody is going to be able to successfully, without having complications, process negative trauma memories, but they still can recover from trauma using regulation and resources. Now, I do think it's important that everybody be able to, to some degree, tell their story, because we all need to be heard, we need to be understood, we need to be accepted, and we need to have our experiences validated by someone else. So that's extremely important. So we tell as much of our narrative as we can, but we also do it duly being aware of what's occurring now, and this keeps us regulated while we're going through things. Now, so that's the general approach as we start with the positive. Now, the other thing I encourage people to do is to turn their attention to things that are positive. I often say there's nothing we can do about our circumstances a lot of times. We don't can't change our feelings that are what they are. In cognitive behavioral therapy, we say, well, we can change our thinking, but that's very difficult to do, particularly if you're very highly dysregulated. And we can't change our behavior directly. We can't just say, well, stop being depressed or stop drinking or whatever the problem might happen to be. So what I always say is the one thing we have ability to guide and direct is where we turn our attention. There's hundreds of thousands of stimuli coming at us every moment from all directions, and we choose what to attend to. For instance, right now I'm attending to my talk and attending to try to get the points across to you. I'm not aware of what's going on in the room around me or what's going on outside. I'm not even aware of what other sounds there may be in the room or that sort of thing. I'm choosing to attend here. Now, if we learn to choose to attend to the positive in negative situations, we can develop a great sense in training and healing. One of the things we know is that we're all biased to the negative. And this is because our brains have developed over thousands and thousands and thousands of years, not to make us happy, but to keep us alive. So if we have a negative bias and assume the negative, we're more likely to stay alive and pass on our genes than those of us who might think, oh, something that looks maybe as dangerous, and we think, well, it's really not, and we look on the positive side of it. So what I say is the negative experiences stick to us like tar or glue, and we have to cultivate the effort to move towards the positive. And I'm not talking about positive thinking or pie in the sky thinking at all. What I'm talking about is turn your attention to the one or two things that are positive within the negative situations, and that we always have that opportunity to do so. Now, this is very hard at first, but we can train ourselves to do that. So that when I work with somebody, they may have a lot of problems, and I know they have difficulties, and I don't want to minimize that in any way, but I want them each day to begin to recognize what happened during that day that was actually positive, and that even in a day of very negative experiences and high anxiety and depression, that there's still something positive that they can experience. I actually have them do an assignment where at nighttime they write down three things that they did well during the day. Now, this is not three things they're grateful for. I love gratefulness lists, but that's not what I'm talking about here. Or three good things that happened to them, but three things that they did well. And this helps us encourage ourselves to know that even on our worst days, we are doing things that are good, that are positive, that are showing growth in ourselves. So that's one assignment that I give. The other thing is we want to stay away from labeling people. Labeling leads us to, unfortunately, this basically taking our sense of other people and doing harm to them or damage to them or disrespect to them, whether we want to or not. So I don't use the terms like borderline personality disorder because that implies there are some others, something different than we are. I like the idea that we're all human. I don't want the idea to go across that, well, I'm staff and you're patient, or I'm normal and you're borderline, or I'm fine and you're mentally ill. We don't want to do that because we'll always find some way to misuse them or mistreat them or disrespect them. And that's just built into our brains and built in and wired into our system. Now, I tell a story on myself sometimes where even though I preach this all the time, it happens to me, and I do it the same as everybody else. One time I had a young woman come to me while I was here at Sierra Tucson, and she had schizophrenia. We don't usually work with people with psychosis, as they don't do very well here, but she happened to be here, and I was not her psychiatrist, but she was agitated, so I saw her one day, and she became very frightening, agitated, angry, and threatening in the office. So I did what we were told to do, which is I removed myself from the office and went outside with her. There were other people around, and then she tended to calm down a little bit. And we were able to talk about what plans we'd make, that we'd give her some medication, let her get some rest, and then I'd talk to her later. And I turned around and walked away, and she caught me. She said, "Dr. Seymour," and I said, "What?" She says, "Aren't we going to have a proper goodbye?" I did not do a basic thing of respect because I had somehow in my mind labeled her as different, as schizophrenic. So although I preach this all the time, I still do it myself. Now, we're going to have to wind up in a minute, and that's basically all I want to say, but I want to leave time so that we have any questions. So please feel free to ask any questions, and I'll try to follow up with answers as best as I can. But I really enjoyed the opportunity to talk with you, really glad that you're here, and thank you for joining us. Now we'll go to questions. Okay, one question here is, why should we think of trauma not as a disorder, but as a normal adaptation and response of the nervous system to psychological trauma? Basically, because that is what it's about. We all have adaptations. We are all doing the best that we can in trying to deal with what we have in life, and we must assume that people are doing the best that they can. So we look at and say there was reasons why we adapted and went to the behavior and the types of things we've gone to, because they were protective of us when we were younger. The problem is that those mechanisms, those symptoms, those adaptations are not helpful in our current life. So we have to learn how to begin to change them and learn better coping skills rather than just using the same old ones that we've always used. I have another question that says, I would love to hear your strength assessment tools for my private practice. What I will do is I will give the resource sheet over to Courtney Martinez here, who can then have it available to distribute to anybody who's interested in that. It's a very simple thing, but it's really a great place I found to start. Okay, with the ACE survey, how many of them, the 10 experiences, do we have that would be considered complex post-traumatic stress disorder? Well, one of the things we know of is that if we score them as one apiece, and if any individual has 4 or more of those adverse experiences, almost invariably they will have significant psychological disorder in their life and significant physical problems in their life that are related, and definitely a foreshortened lifespan. So it's the more of those you have, the worse that it is. But we use a cutoff of basically a score of 4 that really tells us when we're going to really develop a lot of psychological difficulties. Let's see, another question. What key principles are important when working with trauma patients? I think the key principle is to basically love the patients. One of my favorite mentors is Ron Kurtz, who was in the 70s and developed the Hakomi method of psychological therapy. The Hakomi method was the precursor to other somatic therapies like somatic experiencing and sensory-motor psychotherapy. And what he said is, my first inclination when I see a patient is to find something in them to love, to admire, the heroic. So I think this goes beyond what we think of as normal loving kindness for our patients, because loving kindness can also be that we are somehow superior and we're just offering them the loving kindness that we want to offer anybody. But if you look for something to admire in the patient or the client, look for something that's heroic in them, they will know that. They will know. You don't have to say it. They will know by your demeanor and your attitude that you're really looking at what is good in them, what is right in them, where their strengths are. And so I tell all my therapists that I work with that if you cannot find something to love in your patients or clients, really have somebody else to see them. And because we need to do that. And that's the first and most important principle. I think it's time for us to wrap up. It's wonderful to be here. Thank you.